Hi guys, Dr. Gillard again. We are going to go over the lecture that we missed last week, and that would be week 4, CVP Pathology, summer 2016. We're going to talk about venous insufficiency, thrombosis, i.e. blood clots, and embolism. So it's an important lecture. It's about 130 slides, so maybe just a little bit longer than usual, but this will be on your midterm. So study this stuff hard. We'll be giving you a review to help kind of focus you in. I know there's a lot of material, but okay, here we go. So chronic venous insufficiency, thrombosis, and embolism. Some very important things. 2 of the 3 can kill you. So that's always interesting. So let's get going here. Talk about venous disorders first. So chronic venous insufficiency. We talked about this in lab a little bit. It's commonly overlooked by healthcare providers because they don't understand it. United States, the prevalence of CVI, or AKA as chronic venous disease, is about 25 million. So it's a pretty big number here. It's been recently reclassified by the people who classify the authorities on this, the American Venous Forum. But its former classification was an absolute mess. Not quite as bad now, but we're not going to worry about all those classifications. So what the heck is it? It's defined as a condition in which venous blood has difficulty getting out of the deep system back into the lower extremities. In other words, the venous blood backs up into the lower extremities. It can happen in the upper extremities too, but pretty rare. It's mostly lower extremity problem. And so what? Who cares about it? Because it causes increased intravenous pressure within the deep system, perforators, and superficial system. And if you don't know the difference between the deep system, superficial system, and the perforator system and the reticular system, go back and review those notes because you have to understand a little bit about that. Okay, so this increased intravenous pressure, i.e. venous stasis, sometimes just called stasis, it leads to all types of problems, right? Or a train of pathological sequelae. What does that mean? That means a progression of pathological stuff that happens as a result of this increased pressure. So, etiologies, so it can be caused by anything that stops the exit of venous blood from the deep system. So anything that impedes blood from getting out of the deep system, or anything that impedes the superficial system as well. Remember, if the superficial system sometimes acts as a secondary escape route for the blood returning to the heart. So, but it's talking about something has went wrong with the deep system and blood can't get out. It's being blocked by something. And that something is typically venous thrombus formation or a deep vein thrombosis, which has it's either blocking it physically right now, or they've had DVT in the past, and the DVT almost always destroys the valve, so the valves become incompetent. That's called valvular incompetence. And it's not just from DVT. You can be congenitally not blessed with having great veins in the deep system. Obesity can do it. We'll talk about that, how it increases the pressure in the abdomen, and that can kind of squeeze on the deep vessels and increase the venous pressure in the lower extremities from that. We'll talk about that more in a bit. What if you're paralyzed? What if you're in a wheelchair? What if your calf muscle pump, the soleus, isn't working real well, and that calf muscle pump or thigh muscle pump isn't working? That can cause it as well. Then blood will have trouble getting out of the deep system. And rarely you can have soft tissue tumors that could be compressing, say, the femoral vein, so that could cause it as well. So the sequelae of chronic venous insufficiency. Oh, look at that. We got a star here. So I took the time to put a star here. So this is an important slide. It will probably be on the midterm, right? So The backup of blood imparts significant pressure or high venous pressure on the walls of the venules, postcapillary venules, and capillaries themselves. And what did we say about those systems? Those vessels are not designed to handle high pressure, right? They're only designed to handle low pressure. And so what happens? They'll leak, right? You get too much pressure, they'll leak. So what? I kind of blew that, didn't I? Well, so high pressure, specifically, here's what. High pressure overcomes the oncotic pressure. We talked about oncotic pressure, which results in, so you'll have increased interstitial fluid, right? The fluid from the blood will be driven into the interstitium, and the lymph capillary vacuum cleaners we talked about, they'll be overwhelmed. They can't get rid of it, so you're going to swell. And to the fact you might even have the pitting edema we talked about last week. So you can get extravasation. What's that, extravasation? Well, that's where a red blood cell is actually driven out through the capillaries where they're not supposed to be in the interstitial fluid, right? But they can be driven out and they can explode once they get out there, and they release hemosiderin. This usually occurs in, remember we talked about this, the gator area. Where's that? That's the area around your medial malleolus and lateral malleolus. And so that hemosiderin results in hemosiderin staining. If it goes on long enough, it's more than staining. The skin gets really hard. Remember, it looks like a champagne bottle. And you get brawny indurations of the skin is the key, maybe board word there, right? So these are key words, hemosiderin stains, brawny indurations. What is that a sign of? It's a chronic venous insufficiency. You also get, as a sequela, the local tissue ischemia. What does that mean? Well, this swelling in blood vessels and hemosiderin, remember that nutrients and waste and oxygen has to diffuse in and out of the interstitial fluid to get to the tissue. So now it's got all this junk in the way, and the tissue is going to be starved of oxygen. It can't get there. So eventually you start to form, typically after hemosiderin stains and brawny indurations, then you get venous ulcers. You don't take care of the venous ulcers, the tissue can die, and you can develop typically a dry gangrene, which won't kill you, but you could develop wet gangrene, which can kill you. So this could be a life-threatening situation. Rare cases, well, we'll talk about that in a bit. I don't want to get too far ahead here. On the other side of the coin, it can stretch out these structures. So the system, the vessels are under this high pressure for so long, it'll start to damage the walls, the components of the walls, and they'll stretch out. And now you have the first sign. If it stretches out the tiny little vessels, you get something called telangiectasia. That's going to be on the test, I can guarantee you. Telangiectasia, aka is venous spiders or spider veins. And this, we're still on the venous system, maybe the venous side of the capillaries. It can also stretch out the medium-sized vessels or even large vessels if it happens in the superficial system. And that leads to things like reticular veins. That's the next size up. And then the big ones are varicose veins, and we'll talk more about those. Okay, here's a nice example of brawny indurations. So if your patient came in and you're doing a workup, he had sciatica, and you looked at his leg and gator area here, you saw this, you'd have to start asking some questions about what? Have you ever had blood clots in the past? You know, these are hemosiderin stains. He has high venous pressure, venous stasis, and it's resulted in blood cells being destroyed, releasing hemosiderin. So you gotta find out what's going on there. There's pitting edema. We saw these slides in lab. There's our friend the varicose veins. There's reticular veins. There's a venous spider right here as well. So that's telangiectatic right here, but this right here, not quite big enough to be a varicose vein. Getting close though, and these are medium-sized veins, so they won't get much bigger. It's got to be the larger veins that turn into varicose veins. It's a nice picture of telangiectasia there. Matter of fact, let's talk about it a little bit more. Spider veins, venous spiders. Some other texts I've read called them feeder veins, hyphen webs, tread veins. These are probably the big ones right here, though. And so it's a confluence, like remember the confluence of sinuses in the dural system. So it's a confluence of dilated interdermal venules. The key is, oh, look at that, I underlined it, right? That's stuff you should be studying. They're less than 1 millimeter in diameter. 1 millimeter in diameter makes up telangiectatic vessels. Small veins, venules of the reticular system, they become permanently dilated. We talked about this already. They also have, do they have valves? Do these little veins have valves? Yeah, absolutely do. So they can get wrecked as well, and that kind of perpetuates the process. Okay. Now, typically not a health problem here, but they can become itchy, and they can lead to other sequelae of tissue ischemia around the other part of the area. Some causes. Excuse me. Some causes, of course, the big one we're focusing on is venous insufficiency, dermatomyositis, lupus can call it, scleroderma, Cushing's, cirrhosis, too much estrogen, oral contraceptives can actually bring them out, pregnancy, metastatic carcinoma, quite a list here. So I don't think you need to know that for the test, but we're focusing on venous insufficiency, but other things. Maybe we can add one, like metastatic disease. But now let's just focus on venous insufficiency is good. So now spider telangiectasia. Now this is a little different. Okay, now so don't confuse this with venous spider or spider veins. It's not quite the same story. So the spider telangiectasia, these are venules still, but they're described only in the upper extremity, upper thorax or head region. Okay, so they're supplied by veins that, we don't need to worry the names of them, but they feed off or they come off the superior vena cava. So they're similar with venous spiders and spider veins, but they are of the upper extremities. See a picture here, some spider telangiectasia. Okay. They look exactly like telangiectasia of the lower system. So color theories. There's a lot of different theories about color. There's two big ones. Some authors believe that the color depends on how stretched out the diameter, the natural diameter of that venule was. So if the vein stretches between 0.5 and 1 millimeters, then the color is dark blue. If it stretches if it stretches between 0.1 and 0.5, so not quite as much, then they're red in color. Remember we talked about how venous blood is not blue. It's both venous. We've all had our blood taken, right? And you see the blood come out, it's a dark red. So it's still red. It's darker. Arterial blood is, because of the oxygen, is a little bit bright red in color, but there's no blue blood. It's just how the light is reflected off the skin, so it's kind of an illusion. But that's one theory. Another theory suggests that it's got to do with the degree of oxygenation, and the more red ones are on the arterial side, in the arterial side of the capillary, and the blue ones are more on the postcapillary venules and venous side. But I think this one probably makes more sense to me. Reticular veins, you can see a nice one right here. Okay, so key is, look, it's red, it's underlined. So they're dilated subdermal veins. Remember we said the reticular system is right under the dermis. Who's it fed by? Remember that one? Who's the reticular veins fed by? Well, those are just the vessels. Those are the venous plexuses within the dermis itself. So directly by the arterial, the artery side. So 1 to 3 millimeters, you're going to, if the valves within them become incompetent, the valves are going to blow, and that's going to steadily increase the pressure as more and more valves become incompetent. These things start to get bigger and bigger. And who do these feed? These feed the superficial system. What's this? This is varicosities. These are varicose veins of the large. This is a small saphenous vein here. That's varicosed. So talk about varicose veins a little bit more here. AKAs are varices, or varicosities. I'll use that term a lot. Dilated, visible, tortuous veins of the lower extremity. Got to be greater than 3 millimeters in size to be classified as a classic varicose vein. And these are measured standing in the upright position. Some fun facts: roughly 10 to 20% of the general population will develop varicose veins. That's from Rubens. The prevalence will rise to 50% over the age of 50. So they're very common. You'll run into these all the time. Remember in lab we said to always palpate them to make sure there's no hard nodules within them that could indicate blood clot. Anyway, only rarely do these become clinically significant. However, they can be fatal. I think if I remember right, I think I put a case study in here. But they can definitely cause sequelae adjacent to them because the tissue, small veins that are coming off, probably not working the greatest, and the tissue, they can lead to tissue changes around them. Embolisms can occur, or thrombus formation, which could lead to an embolus, could occur, but it's rare. Why is it rare? I think that's actually a question in the midterm. Why is it rare? Well, because remember the superficial system doesn't go up, right? It does not drain into the pelvis and heart. It dumps into the deep system. So the emboli have trouble getting through what connects the deep system to the superficial system? Perforator system. So they have trouble getting through the perforator system. So a lot of times we're not that concerned about them. The vicious cycle, a lot of red, a lot of underlining, so produced by prolonged increased interluminal pressure. So the vascular pressure is just high all the time. It weakens the vessel walls we're talking about superficial large vein problems now, varicose veins. So the weakening in a vessel wall allows them to stretch out too much. And as the vein gets bigger and bigger, pretty soon it's going to pull apart the valves so they don't work anymore. So the valves get more and more incompetent, and they allow more regurgitation to occur. And remember again, the veins are not a high pressure system. They're broken up into columns by the valves. So each column can withstand the pressure within it. But now if two columns coalesce into one column, you've just increased the pressure. The vein walls aren't going to like that. In fact, they're going to expand even more. That's going to affect the next competent valve in the chain. And that valve is going to start to become incompetent. Now you've got 3 compartments, and the walls are going to stretch even more. And that's going to blow out the next valve. So now you've got 4 compartments of that vein, and it's going to stretch even more. And now by this time, you can even see the varicosity. You can see the varicose vein developing. So that's kind of the vicious cycle. So everything I said right here, here's a normal vein. You can see one valve has become incompetent. So here's these compartments I'm talking about. Now these 2 compartments are connected, and the pressure is too great. It expands even more. Now it blows this valve out. So now we got a 3rd compartment. Down here would be a competent valve, but that one's going to blow up pretty soon. So that's the vicious cycle. And they can be pretty nasty looking. Surgically, these can be removed, though. Let's see. Okay, everything we said right there. Target? Who's the target of varicose veins? Well, superficial venous system, especially the saphenous vein and the accessory veins. What are accessory veins? Those are the veins that come off the saphenous system of the lower extremities. So these are the most common site for varicose veins. Why are they the target? Well, because the venous pressure in these vessels, as more and more compartments come involved, can rise to even 10 times above normal. And putting them in the position of dependence, what's that mean? A position of dependence. That means sitting or standing, right? Now you got gravity kind of coming in and making the situation even worse. Some risk factors for varicose veins. The older you get, we already saw an example of that, the more chances you are, maybe the longer those veins have been exposed to gravity. Females are more typically affected than males. There's a very strong hereditary component to this. If your mom or dad has these, there's a decent chance you'll have them as well. Obesity is a factor, so greatly increases the chances for varicosities. The increased intra-abdominal pressure will transfer that pressure to the venous system. It squishes all that fat, squishes down on the vena cava, inferior vena cava, and it kind of backs up the system that way. Plus, the extra subcutaneous fat doesn't support the vessel walls in the lower extremities and can cause trouble there. Another risk factor is a history of DVT. That's a big one, right? Because DVT wrecks the valves of the deep system, so that's going to increase the pressure in the deep system. Let's see here. Deep venous blood will start spilling into the superficial system, which greatly increases venous pressure, leads to superficial vein failure and varicose. Varicosity is the same way. Occupation is a big risk factor. Maybe a retail clerk who's standing all the time. Although at least they're standing, they're usually moving around. Someone who sits a long time is in trouble because they're not engaging the calf muscle pumps. Pelvic tumors, just like the obesity thing, can compress the iliac vessels, inferior vena cava, and raise the pressure that would be upstream, down in the lower extremities. Congestive heart failure, maybe the heart can't keep up, and its blood is backing up all the way down into the lower extremities. What would another sign of that be if blood is backing up all the way into the lower extremities because your heart isn't working? We talked about that in lab. External jugular vein is going to be kind of bulgy now, right? We talked about that. Not a good sign. So severe varicose veins may spontaneously bleed. I told you the story about my wife's coworker who all of a sudden started leaking blood, and she didn't even seem to notice it, and there was a big pool. She was pretty heavy as well, so that was a contributing factor. But typically they're not life-threatening, but not all the time. Here's a journal of the Royal Society of Medicine, quite a very prestigious journal. Here's a report back in 2008 of a fatal bleed from a varicose vein. So they're trying to make physicians aware that these things, venous insufficiency, varicose veins, you gotta not just blow them off as being, nothing, because they can cause trouble. Surgical removal can be accomplished if they start getting real ugly, or if you start having trouble with thrombus formation in there. Or, of course, if you have surgical removal of your limb, if you start having a wet gangrene. Other varicosities. Now, this is an important one here. I'm not sure if I had put this one in last quarter, but this is really good. Esophageal varicosities. So varicosities don't always occur outside. They can occur inside the body as well. And one important clinical region is the distal esophagus, right where it connects into where a Barrett's esophagus can occur, or the esophageal, the gastroesophageal junction itself. There's different, if you really get into this, there's three regions. There's the cardiac and fundus region can also have varicosities. But the distal esophagus, I'm just going to kind of combine these two in together. But it's a medical emergency if this thing starts bleeding, because this one can kill you real fast. On average, a 20% mortality rate for the first bleeding event. All right, that's almost a quarter of the patients will die. Trouble is they might not know it's even happening. For larger, that's for your average of small, large, and very large. So it's even the mortality rate is even harder or even higher for larger varicosities. So now we're looking down your throat with an endoscope. So here's the middle and distal esophagus. Stomach would be, if we keep going down the tube, it would be right down there. Notice we can see some tiny little veins here. See the little ones? Completely normal. A little gastric or a little juice coming out there. Normal. There's a little bit bigger one right here. Those are all completely normal. How's this look? Okay, this is not good. It looks almost like varicose veins, but from the inside out, and that's exactly what it is. These are fairly large varicosities of the distal esophagus, so not a good thing. If you can't see them, I put some little cool red stars, or not, I don't know what those are called. All right, let's talk about them. What's the etiology? Number one cause of varicosities in this region: increased portal tension, portal hypertension. Remember the portal vein? Remember we studied that in Gross 2? Important system. We just learned the portal, hepatic portal vein. That splits into what? Splenic vein, superior mesenteric vein. That's all the farther we got. We didn't even see the inferior mesenteric vein. But there's a lot of other connections that we didn't bother to teach you, which some of which are quite clinically important. But this portal hypertension, normally the blood flow is going into the portal vein, into the liver. If you have cirrhosis of the liver and you have an impedance to blood flow can reverse. It can start getting backed up through the portal vein and through all its tributaries, and it can get backed up so much it can lead to the contribution of the portal vein that goes to the distal esophagus, as we'll see in a second. Bottom line, cirrhosis of the liver, number one cause of esophageal varicosities. What causes cirrhosis? Alcoholism, hepatitis, and viral disease. And the portal hypertension occurs in 90% of patients with cirrhosis. So cirrhosis almost equals portal hypertension. Other causes, there's schistosomiasis of the liver. So those worms can get in there. But that is actually the number one cause in developing nations, but not in the West or countries that are developed. You can have tumors of the liver, thromboembolic disease. What's that mean? Thromboembolic disease. Well, it's an embolism that has come from a thrombus formation, which we're going to talk about. But you can have an embolism stuck in the portal vein as well. So as I said, instead of draining the distal esophagus as usual, the portal vein is reversed in flow, and it goes backwards, and it flows through the portal esophageal veins. Recall from your anatomy, we just went over that. Oh, no, we didn't go over this. Hopefully they went over this in lecture. But the portal vein contribution is, there's a big branch, we'll see in a second a picture, but there's a left gastric vein that comes off the portal system, and that's the one that dumps into a hepatic portal vein. And there's a portal esophageal vein that comes off the left gastric vein. And off the proximal, heading proximally, there's another venous system that dumps into the azygous system. That can actually get flooded with extra blood as well. Let's look at a picture. Here's the liver. Here's the portal vein, which we saw in lab. Left gastric vein is right here. We didn't see that one. That's a new one. There's the splenic, would be here. Superior mesenteric's out of the picture. Those are the ones we saw. But look off this left gastric. There's a little branch here, And here's the stomach, right? And here's the distal esophagus. There's a lower esophageal tributaries from the left gastric artery. So these are the ones that bleed and can kill you right here. And that's because blood flow is usually going this way. And if this is backed up, the blood flow starts reversing this way. And remember, the venous system can't handle high pressure. So when it gets backed up, we have high pressure here and blood starts leaking out. Okay, so when the intravenous pressure rises above 12 millimeters of mercury in these esophageal veins, it's supposed to be 10 is the highest it's supposed to be. You start leaking. The veins can be like those ones we just saw, and they can start hemorrhaging both inside and out. And they can leak severely, and it's a medical emergency. Maybe the first sign that shows up is that classic black tar-colored stool. So the patient says, I got these poops that are really, really dark and ugly looking. So that could be it. Let's see. So acute, fun fact here, acute hemorrhage of these varicosities is one of the most common causes of death in patients with chronic portal hypertension. Okay, here's another picture. I think we just covered this already, but here's the esophageal branch of the hepatic portal system. Blood usually flows this way, but not this time. It's being backed up, and you can see it's leaking here. The veins are becoming stretched out, tortuous. And here's the anastomosis. Here's the azygous system, which is also going to dump into the superior vena cava. So it's really the systemic venous system, but it goes through that azygos. Remember that azygos vein? So the blood can actually start backing up into this azygos system as well, and can bleed from that as well. There's another nasty one here. That's that same view. So some really bad varicosities here. This one this is after the treatment, right? It looks like they banded this. So they can put a rubber band, almost like they do for hemorrhoids. They can put a band around them as one form of treatment to kind of kill it. And this will scar shut. That's kind of beyond our scope, though. Let's talk about caput medusa. So the portal hypertension can also affect and reopen the umbilical vein. Remember, the umbilical vein is a remnant usually. It's trapped in we saw ligamentum teres in gross 2. Or the round ligament of the liver. So ligamentum teres has an umbilical vein built in from fetal days. And if the portal hypertension builds within the liver, it can reopen that. In fact, it can cause varicosity of that thing. That feeds the para-umbilical veins. There's a whole nest. I won't get into all the names, but there's a whole nest of veins around the umbilicus. And the pressure can back up right into that, and you can get a nasty-looking varicose veins around the umbilicus, which is called caput medusa. Remember that from your studies, Greek mythology? So there it is. Para-umbilical veins are severely varicosed here, right? So that's from portal hypertension as well. And it can be more generalized if the other veins are involved. This is another form of caput medusa, not quite as dramatic, but from a patient with liver failure. Okay, switch gears, thrombosis. Here's a quote from Robbins. Thrombosis is one of the scourges of modern man because it underlies the most serious and most common forms of vascular disease. Scourge of modern man. Let's talk about it. So let's do some definitions first. Thrombosis is the process of forming a thrombus. Thrombosis is the process of forming a thrombus within a blood vessel. It can happen in the heart and during life. You have to be alive to have one of these. It's different after you die. You get a blood clot. It starts to develop on top in the luminal surface of the endothelium or endocardium. Venous thrombosis is the process of forming a thrombus within a vein. Pretty simple. Thrombus, what's a thrombus then? Well, the process of thrombosis forms a thrombus. So it's not quite an AKA for a blood clot, even though it's thrown around very loosely. It's a little different. It's an aggregate of coagulated blood. So a blood clot starts, but then it goes further. It contains platelets and fibrin, that's the big one, and other trapped cellular elements. So that's what makes a thrombus. It's more dense. It has more different types of cells than a blood clot. Thrombophilia, that's a term that we need to talk about. An AKA would be a prothrombogenic disease. Hypercoagulable state, thrombophilia, these are all pretty much AKAs. So it's any condition which creates a propensity for thrombus formation, or any condition that you happen to have that increases your chances of thrombosis. Perfect example is factor V Leiden. That's the most common blood clotting. When it's in the blood clotting cascade, it's factor V is important for the formation of blood clots. There's factor V Leiden means that it's a mutation of, I think it's just a single amino acid. But the bottom line, the thing that breaks down blood clots and tells factor V to get out of the picture and release the blood clot, there's a mutation on those receptors. So the enzymes that break down factor V can't bind, and bottom line, they can't break it down. So it stays around way too long. A blood clot, back to our definitions, I digressed a little. Blood clot is a product of the coagulation cascade. It can occur after you die or in vitro. So this can happen outside of blood. But it's the precursor to a thrombus still, but it has no entrapped cellular elements within it. That's the difference. Hematoma results from a leakage and formation of a blood clot outside of a vessel. Also has no entrapped cellular elements within it. Venous thrombosis refers to an occlusive thrombus formation in a vein, which commonly occurs in deep veins of the lower extremities. So venous thrombosis is the big one. These thrombus formations can be deadly, right? They can break loose and embolize. But such formations would always be called deep vein thrombosis or deep venous thrombosis or DVT. If the thrombus occurs in the superficial system, then it's called a superficial venous thrombosis or SVT. Not nearly as clinically concerning. So the incidence of DVT is not completely known. Why? Most cases are not detected because people don't even know they have them. We're getting little DVTs all the time. Our lungs are getting hit with those things. One study demonstrated of hospitalized patients for disease other than the cardiovascular system, like brain cancer and things like that. Study showed that 30% of these patients suffered thrombosis, which embolized. So the prevalence and incidence of DVT is perhaps higher than we think it is. According to HHS, or the Health and Human Services Department, 2008, there's 350,000. I need to fix that. It should be a zero there. Approximately 350,000 individuals are struck down each year with a DVT, PE, so that's an embolism that came from a DVT. DVT predisposing factors, the big giant one, guarantee this. Oh, look, I put a star even. I got really excited about this. Memorize this. Your patient of a long time has a DVT, he's in the hospital, he's got neck pain, not related to it, but they go to some little tiny hospital which doesn't perhaps have the best doctors in the world. And you come back and you talk about the DVT, and you say, well, did they work you up? And they work me up for what? So if someone has a DVT, you need to find out, or in a PE, you need to find out why. So they should be seen by a hematologist, and they should have all their blood checked for factor 5, factor 8. There's a whole bunch of things. They need to find out why that is. Why? Who cares? Because of this one, cancer. I know, probably a half a dozen people who the first sign of their prostate cancer and different cancers, first sign was blood clots. So very important here. Congestive heart failure, acute MI, increasing pain, hypertension, smoking, pregnancy, especially pregnancy here, greatly increases the risk for DVT and PE. Obesity also. Long distance travel we'll talk about. That's a big one. Another big one is after hip surgery, after knee surgery. Remember that famous Pete Wilson, who was a KGO, famous, very well-liked KGO radio talk show host, had a simple hip replacement. I think he was 55, died of a PE. So very, very real, and let's keep talking about it. Thromboplebitis, we're still in definitions. Thromboplebitis versus phlebothrombosis. Okay, confusing. Really trying to get away from these terms. They're undoubtedly still on the chiropractic boards, but the both are used. They're not inappropriately. Both associated with inappropriate thrombus formation of a vein. So that's what they have in common. Some authors use them as AKAs, including Robbins. A lot of other, Robbins is not, remember that's a general pathology book, but the venous books separate these out, although they note they're trying to get rid of these terms. So what's the key to differentiating these things? So a pre-existing endothelial inflammation is the key. So if there's an inflammation predating the thrombus formation, that's the key right there. So thromboplebitis is thrombus formation within a vessel that's already been inflamed. Thromboplebitis. So it occurs on top of the inflamed vessel. It can occur in any, also another differentiating factor, can occur in any part of the venous circulation, the arms, the brain, dural sinuses, anywhere. It's typically secondary to an infection or some type of trauma after an injury or Berger's disease. Remember we talked about Berger's, the smoking disease. Phlebothrombosis, on the other hand, is an AKA for deep vein thrombosis, or DVT. Robbins actually agrees on this AKA. So it refers to thrombus formation within a deep, non-inflamed venous endothelium of the lower extremities. Okay, typically secondary to prolonged immobility, bed rest. You get injured and you're laid up in the hospital. Chances go up, especially if you have factor 5 now. Prothrombogenic disease. There's that word again. Prothrombogenic. That means you have a predisposition to clotting, aka hypercoagulable state or thrombophilia. Factor 5 is the great example of that. Phlebothrombosis continued, so quite frequently completely occlusive. So DVTs usually, remember we talked about arteries, a lot of times it'll cause a downstream ischemia because it doesn't completely clog off the artery. Not true with the venous system. They typically completely occlude the artery. They also have a tendency to form long luminal casts. Talked about that in lab, how they can back up, and in some cases we'll see they can take out the entire deep system. So pretty scary. Although luckily that's a rare type thing. Typically, these types of thrombus are composed more of red blood cells and less of platelets. So here's a good board one right here. There's the etiology of thrombus formation, Perfect Storm. Great movie, by the way. Sad, though. There's a classic triad of patient conditions which greatly increase the chance of developing thrombi. What's the difference between thrombi and thrombus? Thrombi is plural. Thrombus, singular. Know this word, Virchow's triad. If a patient has Virchow's triad, he's at great risk for DVT. So triad, there must be three things. So abnormal vessel wall. It's an endothelial injury. Typically, the endothelial injury is secondary to, not a knife stab. Inflammation, like atherosclerosis process, hypercholesteremia, cigarette smoke, particles of cigarette smoke. So that's very common. So just about everybody has, not everybody, but a lot of people have that one leg of the tripod, I guess. Hypercoagulable state. Now this is not quite as rare. So factor V Leiden is one. There's a whole bunch of them. Factor VIII. Abnormal blood flow is the next one. So you have to have chronic venous stasis. And what can cause chronic venous stasis? Did I not list the best one? Chronic venous insufficiency. The valves are shut. Okay. Other things, congestive heart failure, bed rest, MI, venous problem. And then another one, although this is more on the arterial side, turbulent blood flow. So you can get an aneurysm, vessel narrowing, can cause pockets of really slow moving blood, and they can clot. Although I did say it right there. Turbulence is more an arterial problem. So, perfect storm. How about thrombus in the arterial system? I know several people who've had these things. And it does not occur nearly as often as thrombosis of the deep system. Probably because the arterial system is moving, the blood is moving quite faster. Prevalence is about 3 to 4% of people under 60. Older people, once you get over 70, I think the number was, up to 20% of individuals. Almost always related to atherosclerosis and the turbulent blood flow, or the turbulent blood flow within an aneurysm. Frequently, the arterial frequently completely occludes the affected vessel as well. So I guess I thought it was more of it doesn't always occlude. So I won't put that one on the test. I know the venous side does. But this is Robbins. So downstream ischemia and necrosis can occur. So that's a bad thing right on the arterial side. If that happens in the brain, typically affects in decreasing order. This is actually a question in the midterm, if I remember. It affects the coronary arteries the most commonly, which is bad, right? How can it affect the thrombosis? They get clogged, like for atherosclerosis. Cerebral arteries second, femoral arteries are third. Some more risk factors here. Metabolic syndrome, that's definitely on the test. Metabolic syndrome, so it's middle-age obesity, hyperglycemia, borderline hypertension or greater, hyperlipidemia, and low HLDL levels. So that is the metabolic syndrome, and it's quite common. It's a risk for arterial, the more deadly arterial thrombus and emboli formation. Getting old, tobacco use, previous thrombosis, arterial aneurysm, and cancer. Again, cancer can cause thrombosis and subsequent emboli in either the arterial or the venous system. Histology, so an arterial thrombus, you can always tell the difference versus a venous thrombus. It has this alternating band pattern. Perhaps you studied this in histology already, which there's alternating layers of platelets, fibrin, platelets, fibrin, platelets, fibrin. And they create, you can see these alternating layers here. They create these lines, and those are called the lines of Zahn. Lines of Zahn. These layers, of course, will restrict blood flow and cause ischemia that way. The fate of arterial thrombosis. This is interesting. So if you get one, it's not the end of the world. Sometimes these thrombus can be destroyed by the body's natural thrombolytic system. So the body can kind of gobble these up naturally. but they typically tend to propagate, so they may get bigger in size, which is the bigger they get, the more likely they are to embolize. And they can organize, so they can be invaded by connective tissue, which makes them very hard. And they can cannulize. So cannulization, a new lumen can actually bore through that new hard tissue. So we still don't understand the mechanism of that, but it can help blood flow. So it's another way to help kind of, the body can kind of try to repair these things. The scary one, of course, is embolization, and that's when a piece of this thrombus formation breaks loose and it's off to the races. Downstream it goes, and it's going to get lodged in a smaller vessel. And remember, on the arterial side, it goes where? It could go where? Well, it goes into organs, right, including the brain. At least on the venous side, it's not as dangerous, because when they break loose, where does all the venous return go to? Does it go to the brain? No. It all goes to the heart, and then goes through the heart and goes into the lungs. It can't get through the lungs, right? Because of the capillaries, it'll get stuck in the lungs, which we'll talk about here. So at least that's a good thing. Arterial thrombus versus a blood clot. We talked about this already. You can always tell those lines of Zahn, right? Blood clot, whether formed post-mortem or ante-mortem, does not always have this arrangement. Probably didn't need that slide in there. Not so fun facts about arterial thrombus. Arterial thrombus formation due to atherosclerosis is the most common cause of death in the industrial nations, period. That's from Rubens. Who's Rubens? Rubens and Robbins? Remember, they're both board books. They're both National Chiropractic Board of Examiners books. So when you write board questions, they make you use references, and they encourage you to reference the board books. So these are two books. Anything that comes from these books, whether they agree or not, unfortunately, oftentimes they don't agree on things. But yeah, important book. It's a good book. I like it better than Robbins, actually. The two together seem to do pretty good. I digress again. Let's see. Most arterial thrombi eventually occlude and completely close down the vessels they form, and that's a bad thing. They can cause downstream ischemia, right? And the tissue can die. If that happens in the myocardium, that's a bad thing, right? If it happens in the coronary artery, you get a heart attack. Whatever tissue of the heart that part of the coronary artery fed is now dead. And same thing, if it goes into the brain, any part of the brain tissue that cerebral artery fed is now dead. Not a good thing. Okay, switching back to DVT. I guess I should put that back in the other section next quarter. But risk factors of DVT, stasis or venous stasis. Anything that slows down the movement of blood, number one risk factor. Plane travel over 2-3 hours is trouble. Make sure, if you're older, if you have any factors like factor 5 or factor 5 Leiden, factor 8, make sure you get up every 2 hours and walk around a little bit. You should wear compression stockings, because it's not only the sitting when you're in an airplane. Remember, the cabin is pressurized, but it's never pressurized to atmospheric pressure. It's like being up in Vail, 8,000 feet, right? So your high pressure increases the chances of clotting. I digress again. But that was a good digression. So venous stasis, heart failure, prolonged bed, we went over these. Travel greater than 3 hours, prolonged sitting in a position of dependence. More risk factors: injury, inflammation, childbirth, hypercoagulable states caused by oral contraceptives, talked about these, late pregnancy, cancer, thrombophilic disorders like factor 5, factor 8, increased age, sickle cell disease is another one. Genetic factors are a big one, count for about 60% of the risk factors, according to twin studies anyway. Factor 5 Leiden, again, that's probably the third or fourth time I've said that. It's the most common genetic variant associated with DVT. We talked about mutations in the receptors on the surface of the factor V, which make it, the enzymes that are supposed to tell it to stop clotting can't find it. Single nucleotide polymorphisms also increase the risk. Lysis, so the fate of DVTs, similar to the other ones. Lysis, they can may be destroyed by anticoagulant factors. They can organize themselves and form a cannula within them. They can propagate, right? They can form casts like crazy, and these casts can go all the way up into the iliac vessels. When they get up into the iliac vessels, that's dangerous, very dangerous. Probably a quarter of the people die from that if they break loose. Okay, there's some, oh, that looks great, doesn't it? You can tell that leg is swollen up. Not a good thing. Phlegmasia caerulea dolens. It's an uncommon but severe form of DVT, which is a big precursor to gangrene. Extensive casting formation from the calves all the way up into the iliac vessels can occur. And for strange reason, it's much more common on the left lower extremity. There's two different flavors of it. There is a caerulea type and an alba type. Phlegmasia caerulea dolens is the one the literature talks about the most, because it's so devastating. It involves the deep system, the perforators, and the superficial system can all be completely clogged at once. It's a medical emergency. The patient probably won't see you, though, right? He'll probably go right into the hospital. But the caerulea may result, it gets so bad it can cause volemic shock and arterial system backup. It can get so bad. Here's a new case. Patient's son got some sun tanning here, but you can see it's just starting in this patient. See, his leg's just starting to turn. He's just starting to get some color change here. Symptoms include obviously pain, cyanosis, edema. Typically start distal and progress proximally over the span of a few hours sometimes to a few days. And the pain occurs from venous hypertension, elevated muscle compartment. So you get a compartment type syndrome, which is very painful. It can affect nerves as well, which I didn't even mention. Venous pressure may get so high that the skin begins to blister and then become necrotic. So it can actually blister and start to peel off, and gangrene will follow for sure. It's a medical emergency at this point. If caught early and treated like that picture we saw, a quarter of the patients still die from PE, but 75% will live. If it's not caught early, you're probably going to die. Limb amputation, and if you survive, another quarter of the survivors are going to lose their limb because wet gangrene will set in. The treatment is something called a thrombolysis. Talked about that in lab. With heparin, always start heparin first. Watch out for HIT though, right? With heparin, which can make the clotting worse. Won't get into HIT. That's not my department, I don't think. Thrombolysis is a roto-rooting. It's an endoscopic procedure. They stick, basically they put a IVC filter in first from the good leg to prevent any fragments from the roto-rooting, and they basically roto-root out that clot and start removing thrombus formation. And yeah, that's followed. After that's done, if it's successful, the Lovenox is the next step. It's low molecular weight heparin that's injectable into your stomach. It doesn't feel good. I've had to do this myself for a while. Then you'll go on a long-term blood thinner like warfarin's the old standard. It's been around forever. Problem with that is what? You got to do INR testing, which is a pain. The new ones, Xarelto, Pradaxa, Eliquest, no INR testing, which is awesome. But I think they have an antidote for it now. Half-life of this, or there's an antidote for this. So if you're in a car crash and you're bleeding, you go to the ER, they can inject the antidote, and it thickens up your blood so you won't bleed to death. With Xarelto, Pradaxa, and Eliquest, there's no antidote. I think it's at some of the universities. The last I checked, Stanford had it about a year ago. So eventually it will trickle down into the ER rooms. Maybe it's there. I mean, this is 2016. Maybe they have it already, but that's one of the scary things about these. But you don't have to worry about what you eat. With heparin, you can't eat greeny things. You have to watch. It works on vitamin K inhibition. You don't have to worry about what you eat for the most part with these. Okay, except for thrombolysis, this treatment regime is for all DVTs. So you should know thrombolysis. You should know something about this. Here's cerulia. This is the end phase. This guy came in way too late. He's going to lose that leg for sure. Pretty nasty. Occlusive DVT. This is just a picture here. So this patient had a massive thrombus formation in the popliteal vein, and you can see the effects of that. Thromboemboli. Let's talk about it. So embolism, it's the passage of any material through the venous or arterial system, which will lodge or get stuck downstream. Diminishes or occludes the blood flow, which causes, of course, ischemia, necrosis, hemosiderin stains, and ultimately gangrene, venous ulcers, and then gangrene. Most common thrombus formation is a thromboembolus, or most common emboli is called a thromboemboli. What does that mean? Well, that's an embolus, and there's the birth of it. It came from thrombus formation. Do all emboli come from thrombosis? No. But that's what happened here. Here's a real one. And that's a real thrombus formation there. That's not a blood clot, post-mortem. So discovered on in over 50% of autopsies. They're quite common. 90% of these arise from the deep veins of the lower extremities. So as a DVT. AK, what's the AK for DVT? Phlebothrombosis. Other locations, so it's not always the deep system they come from. They can come from the venous system around the prostate, the periprostatic venous plexus, the venous network around the pelvic region, around the uterus, and the dural venous sinuses of the brain can do it. Portal vein can do it. It's not all the time, but those are much more rare. Most fatal ones arise from the iliofemoral veins. And the scary thing about that, if it gets in your vein, the chances are, or if it starts in the calf and works its way up, chances are you'll feel it. But if it starts in the iliofemoral veins, in the either in the deep femoral, common femoral, or the internal or external iliac veins, there's not a lot of pain receptors there. So only half of the patients actually feel the most deadly ones. Pulmonary emboli rarely come from the upper extremity. Symptoms, frequently absent again, but they depend on the size of the embolus, the health of the patient, whether the embolism is acute or chronic, where the embolism lodges. Acute pulmonary embolisms typically present in 4 ways. If they're small, they're going to get stuck in the lung tissue, won't even know they're there. They'll just be reabsorbed by the body. But if they're medium size and they get into the lung tissue, they can cause a transient dyspnea. What's dyspnea? That's trouble breathing, a little labored breathing. Remember, dyspnea or exertional dyspnea is trouble breathing, going up the stairs more than normal. Or tachypnea. Make sure you know those words. They're underlined. Tachypnea. What's that? Rapid breathing. So you go up the stairs, you could have dyspnea, trouble breathing, and tachypnea at the same time. Could be a PE. If they're large, they may cause regional pulmonary infarct. That's not good at all. The lung tissue will die. We talked about that in lab, and that is extremely painful. Causes a pleuritic chest pain as well as an effusion. Hospitalization is a must there. If they're massive, they can kill you. They can get stuck in the pulmonary trunk. They can get stuck kind of at the crotch of the distal pulmonary trunk where it branches into what? Into the pulmonary arteries, right? And if they get stuck, it can wreck your heart. It can back up the blood, all sorts of things. Those are called saddle emboli. If the emboli are numerous, maybe they're not that big, but there's just a whole bunch of them. They can get lodged in a bunch of pulmonary arteries to the point you get pulmonary hypertension, which we're going to talk a lot about. Pulmonary hypertension, it'll back up blood into the right side of the heart, and you can get right-sided heart failure from that. Here's a saddle emboli. I was getting bored, did my Photoshop skills last night here. That's supposed to be a saddle. So this sticks in your brain. There's a sad heart that's split because of this. So saddle embolism, if the pulmonary embolism is massive, it can get stuck, as I just said, in the pulmonary trunk or pulmonary arteries. It's a medical emergency. Luckily, it's only about 3%, 2.6% of these emboli get stuck like this. And when I was up in Vail, I know a doctor who had almost died from this, but they saved him, but very dangerous. Saddle embolism. So let's take a look at this. Let me give you a second to look at this. So it's an arteriogram. You can see there's contrast in the arteries and in the veins as well. So here is that would be the right pulmonary artery and all its branches feeding the lungs. Everything looks okay here, but where's the left? Yikes, right? There should be a left pulmonary artery coming out over here. It's gone. There's a giant saddle emboli in here, which actually killed this patient. Here's a real one. Okay, the pulmonary trunk has been cut open, kind of filleted open. There's the pulmonary arteries, and that, my friends, is a real fresh, just post-mortem, not embalmed anything. That's a fresh saddle embolism. Scary. There's another even fresher one, right? Look at that one. Pulmonary artery's been filleted open. So, some more fun facts, or not so fun facts, about pulmonary embolism. 75% of pulmonary emboli, they don't cause an infarct. Classic symptoms is dyspnea, cough, chest pain, hypotension, low blood pressure. Rarely, about 3% of the time, the emboli can block the pulmonary microcirculation, which results in pulmonary hypertension. Approximately 50% of pulmonary thromboemboli are reabsorbed, that's the good news, within 8 weeks with little sequelae. So that's a good sign. If they don't reabsorb and scarring occurs, you can get pulmonary hypertension. The heart is the most common source. Now we're atrial thrombi. Heart is the most common source of atrial thrombi. Usually comes from several places. Let's talk about those places. So we're switching now. This is the atrial system. You can get embolisms of the atrial system. Where do they come from? Vegetations growing off the mitral aortic valve, secondary to endocarditis. So we'll talk about these more in a couple of weeks. These are bug balls. They're balls of bacteria that can grow on the valves. A mural thrombus. What the heck is a mural thrombus? These are thrombus that are coming off the chambers of the heart, of the lumen, or off the lumen of the aorta. Most of the research, the aorta is okay. We'll include the aorta, but not the other vessels. Probably just the ascending aorta. I probably should have added that in there. The formation is stimulated by a past myocardial infarction. So if you survive a myocardial infarction, a blood clot or thrombus formation could occur on the inside of the heart over the area of the tissue that died. That's quite common. That's called a mural thrombus, and if it breaks loose, which it can, it becomes an emboli, and you can get a stroke from that. let's see what else here. So atrial fib, turbulent blood flow can cause them. Mitral stenosis, myocarditis, catheter trauma can also cause them. So aortic thrombus formation is another way. So thrombus coming from occurring in the heart chamber secondary to atherosclerotic plaque, aneurysmal dilation of the heart walls. Okay, I guess that's it. This is from Rubens, pathology. You can see some of these things here. So atherosclerosis, you can get some plaque. They can throw an emboli. Here's a mural thrombus that occurs in the atrium, secondary to atrial AFib. AFib, the ventricles are contracting, sometimes 500 beats per minute, and all the swishing blood can start to coagulate. So that's mural thrombus from some type of heart arrhythmia. Here's an endocarditis, likes the valves, right? It can stick on the valves. If that breaks loose, you got an emboli or bug ball embolism. Myocardial infarction here in the ventricle would have occurred right here, and it messes up the endocardium tissue. Maybe too many coagulation factors are released and start sticking, and you build thrombus. If you throw that clot, it could go zoom right up here, right up into the brain, and you have a stroke. Atherosclerosis here can do it. Okay, we don't need to talk about these other ones. Some favorite targets, you can look at that. So pulmonary infarct, again, small pulmonary emboli are typically not lethal, but if they get positioned just right, they can cause an infarct. It's about 15 to 20% chance of that happening. Infarct symptoms: 10-10 pain, cough, horrible pain, shortness of breath. Sometimes you can start spitting up blood from this. Pleural effusion is also common. Infarct fate, infarction fate. The blood in the infarct typically is reabsorbed, but you're going to get granulation tissue, which turns into a lump. So that's going to be trouble in that area. So the bigger the infarct, the higher the chances of pulmonary hypertension. Clinical course: small thrombus in the calves are ordinarily asymptomatic. In fact, they don't get too worried if the thrombus is in the calves either. Just have to watch it. And that's a good thing, because the ultrasound techs will admit sometimes it's very difficult to see a thrombus formation in the calves. Large, dangerous thrombi in the iliofemoral system are the ones carry no symptoms at all. We said that. 50% of these have no symptoms. Occlusive thrombus, on the other hand, if it's in the femoral arteries and iliac, or in the iliac, femoral veins and iliac veins, can lead to severe congestion, cyanosis of the lower extremities. Treatment for acute DVT depends on the severity and location of the thrombus. Initially, again, heparin therapy, followed by anticoagulation therapy. We talked about this already. We didn't talk much about it, but if the clot is extensive, then we did talk about this. The thrombolysis, talked about the rotor-rooting, and they'll put this little catcher in here that catches blood clots when they do the rotor-rooting. Or if you have a huge clot and you're throwing clots, they can put this in here prophylactically as well. You see all the lawsuit commercials on TV about these now, because even mine, they had a heck of a time getting mine out. And a doctor who was also going through this procedure, he still has his embedded right in the vena cava. And trouble is, the vena cava, the intima grows around it and can ingrow it. Remember how during the atherosclerotic process, the smooth muscles grow right around the little battle zone? Same thing can happen here. Plus, you can get collateral circulation bypassing this thing, so a clot could still get through. So these are short-term, not a long-term fix, and they do have trouble getting these out. There's a cartoon of it. DVT and valves. We talked about this already, didn't we? DVT formation always destroys the valves, which results in chronic venous insufficiency, as previously discussed. Leads to chronic venous stasis, train of sequelae, dependent leg edema, pitting edema, telangiectasia, hemosiderin stains, the gate area, brawny indurations, venous ulcers, gangrene. Nice slide, nice recap slide. Why do we care about DVTs? Because they, as I told you in lab, they can mimic the radicular pain of sciatica to a T. So very scary. And then we said only 50% of people actually have symptoms with a DVT, especially the dangerous DVTs. So, in orthopedic tests, we talked in lab about Homan's test. You know, the one that's on the boards you've already learned has sensitivity and specificity too, or way under 50%, around 30%. It's terrible. It's almost useless. Although for doing our due diligence, we do need to do that, right? A sudden death rate from a PE is about 20%. Even if you're treated, scary thing. Death is much higher for people who are not treated, much, much higher. Exam findings, the most common physical findings on exam include unilateral leg pain, swelling, warmth, erythema, but again, they may have no pain, no symptoms at all. May or may not be tender. Although you can sometimes palpate the less dangerous superficial thrombosis formation as casts or cords, these are not that dangerous. The deep systems are unpalpable. So any of the above findings are present. A duplex ultrasound, I should have underlined that, is the gold standard for making the diagnosis. Always refer out if you're ever in question. Talked about that in lab. We don't need to talk about that. True story, I think I took that out. Did I not take that out? It's still in here. You can read through that. So yeah, it's basically my story. Only mine ended a lot better than this guy. You can read through that. I thought I took that out. All right, compression stockings. They're important there. After a DVT in the veins, if you have chronic venous insufficiency, you can kind of squeeze the valves back together and help that calf muscle pump system work by wearing compression stockings. They should be worn, especially if you're going in a seminar, all-day seminar where you're going to be sitting like crazy and can't get up that much. Wear compression stockings. If you're going on a plane ride more than 2 hours, wear your compression stockings. All right, let's get to these other parts here. Air embolism, interesting. So air can actually embolize in the venous or atrial system. And the most common risk factor for air entering the venous system is, not surprisingly, some procedure or puncture of a large vein. That is not collapsed. So a working, functioning vein is stuck with a needle, or, a chest procedure of some kind, especially if these veins are below atmospheric pressure, which they often are, right? Because of that negative interthoracic pressure sucking them in. What are the causes? So these are interesting. Seated surgical procedures of the brain. So any type of surgery into the posterior cranial fossa where the patient has to be seated. Look at this study. 80% of the people with these going through this type of surgery are suffering from an air embolism. Hopefully not. That can be any. That doesn't mean a fatal one. But parturition, you should know that word, giving birth. Air can enter through tears in the myometrium and get in. C-sections. One study showed a 40% chance of air embolism after C-section. Hip replacement surgery is a big one. 30% risk factor for PE, or not for PE, for an air embolism. Central venous catheters, cancer patients typically have these lines permanently inserted. They can throw air emboli. Diving accidents. Now this is not the bends. It's as if they ascend too rapidly while holding their breath. So it actually explodes the alveoli in their lungs because the pressure is decreasing as they go up. a small amount of circulating air bubbles. Let's say somebody's drawing your blood and they always backwash a little. That's not a big problem. But the air bubbles, if there's a lot of those little air bubbles, they can coalesce together to form one big bubble, and it can cause obstruction, downstream ischemia. Favorite places for air emboli to get stuck: right side of the heart, pulmonary circulation anywhere, and the brain, unfortunately, if it's on the arterial side. Now the bends, decompression sickness, I didn't put the bends in there, but that's commonly known as the bends. I'll tell you why in a second. So people who work and play underwater are subject to a unique gas embolism. It's usually nitrogen or helium type. And here's how it works. If a diver comes up or ascends slowly, this nitrogen gas little bubbles will form. Small little bubbles will form, but they'll go to the alveoli and they are exhaled. No big deal. But if the diver comes up too fast, the nitrogen bubbles can coalesce together and it can form a big gas nitrogen emboli. And not a good thing, right? Depending on where it occurs. So the bubbles can cause downstream ischemia. If it occurs in a joint, which they typically do inside the joint, hurts like hell, and they bend their knees and elbows and wrists, and that's where the bends comes from, because they have to flex the joint, which increases the joint space volume, which helps take some of the pressure off. Let's see, the second leading cause of death from a diving accident is the bends. I think I said everything right here. Of course, if the embolism occurs in the brain, it can kill you, right? If it occurs in the coronary arteries, you can get a heart attack from this. So don't come up too fast from diving. This is interesting. Amniotic fluid embolisms. These contain fetal cells and debris. So when you're giving birth, the amniotic fluid, the fetal cells, and the junk in the area, they can enter the maternal venous circulation during childbirth. And this is a really weird one. It's rare, thank goodness, but if it does occur, it's only 1 in 800 or 8,000 births. If it does occur, it's typically fatal. Mortality rate has been up to 80%. So this is a bad one. And it will occur toward the end of labor, and these fetal cells, debris, all that stuff will get released into the maternal veins, and it ends up in the lungs. Well, you think, how can it be 80%? It's just another PE to the lung. It's not that high. So we don't quite understand what's going on with this. We don't understand the mechanism, but it's thought to be some cytokine-mediated anaphylactic reaction in addition to the mechanical obstruction as well. But the affected typically gets cor pulmonale. What's that? That means the right side of the heart is swollen up and it's not working. Cor pulmonale, cyanosis, hypovolemic shock from just not enough blood flow typically occurs, and that can be followed by coma and death. Fat embolism, you get a fracture, we all know this. Some of the marrow or fat from inside the bone can get into the bloodstream, and symptoms can occur immediately or may take a while. Not too excited about this one. The most severe form, respiratory failure, mental change, thrombocytopenia. Other IV drug users who use talc as a carrier for their drug may suffer a talc emboli, which travels to the lungs, and it can form a granuloma. You can get a granuloma response, and it turns into a ball, and it can start compressing that vessel and the adjacent vessels. A cotton emboli, I don't think it's around. They don't use cotton balls much when they take your blood anymore, but they used to. And it used to be quite common to get a cotton ball embolism. Schistosomiasis or snail fever, the flat ova of the snail can get into the venous system and travel to the lungs, which again causes a granuloma and can occlude the vessel and the neighboring vessels. Tumor emboli, so the spread of cancer through the blood, can also cause emboli of the cancer cells. Hey, we finished. Thanks for listening. And this was a big lecture, I know, but obviously it's a very important lecture. A lot of clinical stuff in here, a lot of stuff that can kill you. So this will be on the test. If you have any questions, you can email me, or we could talk about it in class. And the midterm will be on week 6 as planned. And thanks for listening.